Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 299 of our pharmacotherapy series, which majors in acute coronary syndrome. The first question reads, Ph.D., a 68-year-old, 80-kilogram man, is being admitted to the emergency department after experiencing an episode of sustained chest pain while mowing his yard. After waiting 6 hours, he called 911 and was transported to the emergency department to a facility without the ability to conduct percutaneous coronary intervention. Physical examination reveals an anxious and diaphoretic man. Heart rate and rhythm are regular, and no S3 or S4 sounds are present. Vital signs include BP of 180 systolic, 110 diastolic, heart rate 105 beats per minute, and respiratory rate 32 breaths per minute. Ph.D.'s chest pain radiates to his left arm and jaw, and he describes the pain as crushing and like an elephant sitting on my chest. He rates it as a 10/10 in intensity. Thus far, his pain has not responded to 5 sublingual nitroglycerin tablets at home and 3 more in the ambulance. His ECG reveals a 3 mm ST segment elevation and Q waves in leads I and V2 to V4. Based on his history and physical examination, Ph.D. is diagnosed with an anterior infarction. Laboratory values include the following: sodium levels of 141 milliequivalents per liter, potassium levels of 3.9 milliequivalents per liter, chloride of 100 milliequivalents per liter, bicarbonate of 20 milliequivalents per liter, blood urea nitrogen of 19 mg per deciliter, serum creatinine of 1.2 mg per deciliter, glucose of 149 mg per deciliter, magnesium of 2 milliequivalents per liter, CK of 1,200 units per liter, with a 12% CKMB fraction. The normal range is 0% to 5%. Troponin I ultra of 60 nanograms per milliliter. The normal range is less than 0.02 nanograms per milliliter. Cholesterol of 259 mg per deciliter. Triglycerides of 300 mg per deciliter. Ph.D. has a prior history of coronary artery disease. A previous cardiac catheterization 2 years ago revealed lesions in his middle left anterior descending coronary artery, 75% stenosis, and proximal left circumflex artery, 30% stenosis. His echocardiogram at the time showed an ejection fraction of 58%. These lesions were deemed suitable for medical management. He also has a history of recurrent bouts of bronchitis associated with bronchospasm for 10 years, diabetes mellitus treated with insulin for 18 years with a hemoglobin A1C of 6.8% obtained 6 months prior to admission, and hypertension with BPs usually 140 systolic 85 diastolic. His father died of an MI at age 70. His mother and siblings are all alive and well. Ph.D. has smoked 1 pack of cigarettes a day for 30 years, and he drinks approximately 1 six-pack of beer a week. He has no history of IV drug use. On admission, Ph.D.'s medications include insulin glargine 40 units daily, albuterol inhaler is needed for shortness of breath, hydrochlorothiazide 25 mg daily, nitroglycerin patch 0.2 mg per hour, and nitroglycerin sublingual 0.4 mg PRN for chest pain. What signs and symptoms does Ph.D. have that are consistent with the diagnosis of acute myocardial infarction? Ph.D. described his pain as a pressure sensation, which is common with ischemic heart disease. The chest discomfort associated with acute coronary syndrome often is described as pressure or as a tight band around the chest rather than pain. Although Ph.D. was involved in physical exertion when his chest discomfort began, this is not always the case. It can begin at rest and, frequently, in the early morning hours. At least 20% of patients with acute myocardial infarction have no pain or discomfort. These episodes are described as silent MIs. Presentations range from no symptoms to shortness of breath, hypotension, heart failure, syncope, or ventricular arrhythmias. Silent or atypical infarctions occur more commonly in people with diabetes and in the elderly. Ph.D. is diaphoretic, a common finding, but other common symptoms such as nausea and anxiety are not present. He also describes his pain as 10/10 in intensity, or perhaps the worst pain I've ever experienced, which is typical of a STEMI. The diagnosis primarily lies in the symptoms, e.g., the patient's story, the ECG, and the laboratory findings. The history of diabetes, hypertension, smoking, and a positive family history in Ph.D. are all risk factors for coronary disease. His admission BP is high, which could indicate poor underlying control or anxiety and stress related to his acute coronary syndrome. The blood sugar of 149 mg per deciliter is high, again indicating either poor control or a stress response. Measurement of glycosylated hemoglobin is indicated during his hospitalization to better assess his diabetes control. The next question reads, what laboratory abnormalities can you expect to see in Ph.D.? Ph.D. demonstrates several laboratory abnormalities commonly seen with both STEMI and NSTEMI. Both his CK-MB and troponin are elevated, consistent with myocardial necrosis. With unstable angina, cardiac biomarkers are not elevated. Several other nonspecific laboratory findings should be monitored in Ph.D. Hyperglycemia may develop because Ph.D. has diabetes, but this can also occur in patients without diabetes. Acute coronary syndrome is also accompanied by an acute systemic inflammatory response manifested by fever, leukocytosis, and elevation of the erythrocyte sedimentation rate and C-reactive protein, as well as a drop in LDL, high-density lipoprotein, and total cholesterol. Specifically, these lipoprotein changes may begin to decrease within 24 to 48 hours after an acute coronary syndrome event, reaching a nadir within 5 to 7 days and then gradually recovering during the next 30 days. Therefore, it is prudent to check serum lipid profiles within the first 24 hours of the acute myocardial infarction to get an accurate determination of the patient's lipid values. The next question reads, Ph.D. was noted to have ST segment elevation on the ECG. What are the implications of an ST segment elevation versus non-ST segment elevation MI? Perhaps the most important diagnostic test in someone suspected of having an acute myocardial infarction is the ECG. The ECG is an important tool because it is non-invasive, can be performed rapidly, is readily available in most settings, and helps determine where the acute myocardial infarction is located, i.e., anterior, inferior, or lateral. P.H.D. has classic ECG changes ST segment elevation, and presence in the anterior ECG leads V2 to V4 points to the coronary artery likely to be blocked. P.H.D.'s previous left anterior descending lesion may have had a plaque rupture leading to thrombosis of the vessel. The presence of ST segment elevation in two contiguous leads indicates severe ischemia and occlusion of the coronary artery. Every effort should be made to open the infarction-related artery as soon as possible, which could consist of PCI or fibrinolytic therapy. If the ECG showed ST segment depression, e.g., NSTEACS, instead of elevation, P.H.D. would not be eligible for fibrinolytic therapy because the risks of fibrinolytic therapy outweigh the benefits in NSTEACS. The next question reads, what are the prognostic implications of an anterior versus an inferior myocardial infarction? Damage to the anterior section of the heart is more likely to be associated with increased morbidity, e.g., left ventricular dysfunction, and mortality. The patients at highest risk of death are those with an anterior acute coronary syndrome, left ventricular dysfunction, and complex ventricular ectopy. P.H.D. is at an increased risk because he has sustained an anterior infarction. The next question reads, what is P.H.D.'s initial risk of mortality based on his presenting signs and symptoms? Using the TIMI risk score for STEMI, P.H.D. has a score of 6 based on his age, for which he earns 2 points. History of angina, hypertension, and diabetes mellitus, for which he earns 1 point. Heart rate, for which he earns 2 points, and location of his myocardial infarction, for which he earns 1 point. P.H.D. has a 30-day mortality rate of 16%, thereby highlighting the serious nature of this event. If P.H.D. had experienced an NSTEACS with ST segment depression, he would have a TIMI risk score of 5 based on his age, 1 point, at least 3 risk factors for coronary artery disease, 1 point, prior coronary artery disease history, 1 point, ST segment deviation, 1 point, and elevated cardiac biomarkers, 1 point. Based on this TIMI risk score, P.H.D. would be at high risk for death, myocardial infarction, or need for urgent coronary artery revascularization within 30 days. The next question reads, are the immediate and long-term therapeutic objectives in treating P.H.D.? With both STEMI and NSTEACS, the immediate therapeutic objectives, particularly as they apply to P.H.D., are to restore blood flow to the infarction-related artery, arrest infarction expansion, alleviate his symptoms, and prevent death. These objectives are achieved primarily by restoring coronary blood flow, administering a fibrinolytic or performing percutaneous coronary intervention for STEMI or performing percutaneous coronary intervention with NSTEACS, and lowering myocardial oxygen demand with nitrates and beta blockers. Any life-threatening ventricular arrhythmias that develop must be treated. The long-term therapeutic objectives are to prevent or minimize recurrent ischemic symptoms, reinfarction, heart failure, and sudden cardiac death. As P.H.D. is experiencing a STEMI, the specific therapeutic regimens are discussed in the questions that follow. The next question reads, is P.H.D. a candidate for fibrinolytic therapy? Is any one agent preferred? STEMI is a medical emergency, and rapid administration of drug therapy is crucial to save myocardial tissue. The results of several major trials have shown unequivocally that if used appropriately, fibrinolytic agents can reduce the mortality associated with an acute myocardial infarction. Because mortality benefit is greatest when fibrinolytic therapy is administered within 2 hours of symptom onset, pre-hospital fibrinolytic therapy, in which trained paramedics administer the fibrinolytic in the field, is an attractive option to reduce total ischemic time. If primary percutaneous coronary intervention cannot be performed within 120 minutes, fibrinolytic therapy should be given if no contraindications are present. For patients who present beyond 12 hours after symptom onset, fibrinolytic therapy should be administered only if there is ongoing ischemia, hemodynamic instability, or a large area of myocardium is involved. In the case of Ph.D., he is admitted to a hospital that is not percutaneous coronary intervention capable and cannot be transferred to a percutaneous coronary intervention capable hospital within 120 minutes of first medical contact. Controversy still exists about which fibrinolytic should be used, the best dosing regimen, the most appropriate adjunctive therapy, and whether the risk outweighs the benefit in some subpopulations of patients, e.g., those with an inferior acute myocardial infarction. Ph.D. has a history of hypertension, and at presentation his BP is 180 systolic, 110 diastolic. A BP this high is a relative contraindication to fibrinolytic therapy because of an increased risk of cerebral hemorrhage. However, Ph.D. has an anterior myocardial infarction and is likely to benefit from fibrinolytic therapy. In this case, he should receive IV nitroglycerin immediately because the onset of BP control with this agent usually occurs within minutes. Once his systolic BP is less than 180 mm of mercury and the diastolic is less than 110 mm of mercury, a fibrinolytic can be administered. The nitroglycerin will also reduce the workload on his heart and may provide pain relief. Because Ph.D. has severe pain and ECG changes consistent with an anterior acute myocardial infarction, he is at high risk for substantial morbidity or mortality. The argument for or against a specific fibrinolytic is probably less important than the decision to use an agent and to administer the medication as soon as possible after the onset of symptoms. Ph.D. is fortunate because he has presented within 1 hour of the onset of chest pain. Options in the United States include only fibrin-specific agents. Riteplase was compared with tissue plasminogen activator in the global utilization of streptokinase and tissue plasminogen activator for occluded arteries, abbreviated as GUSTO-3 trial. Riteplase has a slower clearance from the body, allowing the drug to be given as a bolus without the need for a constant infusion. In the GUSTO-3 trial, riteplase was administered in 2 bolus doses of 10 million units, given 30 minutes apart. The mortality rate and incidence of stroke were the same in the 2 groups of patients. Tenecteplase, abbreviated as TNK, was compared with tissue plasminogen activator in the second assessment of safety and efficacy of a new fibrinolytic, abbreviated as ASCENT-2 trial. Tenecteplase was administered as a bolus of 30 to 50 mg for 5 to 10 seconds, based on body weight. No difference existed between tenecteplase and tissue plasminogen activator in 30-day mortality and stroke, and tenecteplase had fewer bleeding complications. The 2013 guidelines do not explicitly endorse one fibrinolytic versus another, and all are acceptable first-line agents. Selection is usually based on clinician preference and hospital formulary. The next question reads, orders are written for an infusion of tissue plasminogen activator along with unfractionated heparin 4000 units IV bolus, followed by 960 units per hour by continuous infusion. Aspirin 325 mg is ordered stat. Are both unfractionated heparin and aspirin agents necessary? The second international study of infarction survival, abbreviated as ICES-2 trial, showed that the combination of aspirin and streptokinase reduced mortality in patients with an acute myocardial infarction by 42% compared to placebo. In doses of 162 mg or more, aspirin generates a prompt clinical antithrombotic effect as a result of its inhibition of thromboxane A2 production. Thus, immediate administration of 162 to 325 mg of aspirin in all patients diagnosed with acute coronary syndrome is indicated. In the acute setting, aspirin should be chewed because it is absorbed more quickly. All patients should receive low-dose aspirin indefinitely after a diagnosis of acute coronary syndrome. If patients have a contraindication to aspirin, clopidogrel can be substituted. The use of unfractionated heparin as adjunct therapy to prevent reocclusion has been evaluated in many studies. Because P.H.D will receive tissue plasminogen activator, an IV unfractionated heparin bolus followed by a continuous infusion should be started before the end of the tissue plasminogen activator infusion. The ACC/AHA guidelines recommend an initial unfractionated heparin bolus of 60 units per kilogram up to a maximum of 4,000 units, followed by an initial infusion of 12 units per kilogram per hour up to a maximum of 1,000 units per hour for 48 hours after fibrinolysis, with a targeted activated partial thromboplastin time, abbreviated as APTT, of 1.5 to 2 times the upper limit of normal. Unfractionated heparin should always be considered in patients at high risk for systemic or venous embolism. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 300.